Good evening and welcome to our foot and ankle webinar with Dr. Tyler Fraser. We will get started in a moment, but please first allow me to take a moment to explain tonight's format. In order to keep background noise down, all participants other than our presenter are muted. So we ask that you submit your questions via the Zoom chat or Q&A feature, which you will find in your Zoom toolbar. And then at the end of his presentation, we will take questions in the order that they have come in. Now for a brief introduction of OrthoSouth. OrthoSouth is a comprehensive orthopedic practice, but I like to say that our specialty is delivering five-star patient experiences. We have 8 clinics, 2 surgery centers in South Haven and Germantown, physical therapy on site at all locations, Saturday clinic hours in Bartlett, and evening hours at our location on Briarcrest Avenue in Memphis. Walk-ins are welcome at almost all of our locations. We know that you can get competent orthopedic care at many places in the Mid-South, but we consider that to be the baseline. We strive to deliver a 5-star experience and to exceed your expectations with every interaction, every patient, every day. And if we don't do that, I hope you'll let us know. Now, without further ado, I'm going to introduce Dr. Tyler Fraser, tonight's speaker. Dr. Fraser is a fellowship-trained orthopedic foot and ankle surgeon. He practices at our Primacy Parkway, Exeter Road, and Bartlett clinics. He's a native of Arlington, Tennessee, so he's come back home after his fellowship to practice. And he did his undergrad at Rhodes College. He got a BS in chemistry. Went to medical school at UT. So Dr. Fraser is truly, he's a hometown guy. Foot and ankle fellowship at UC Davis and Reno Orthopedic Clinic. His research includes publications and book chapters on hindfoot, midfoot arthritis, turf toe, flat foot corrections, related surgical techniques. His work on foot and ankle conditions has been presented at regional, national, and international meetings. He's a member of the American Academy of Orthopedic Surgeons, as well as the American Orthopedic Foot and Ankle Society. So, Dr. Fraser, welcome, and please take it away.
Thank you, Melissa, and thank you everybody for joining in tonight. Hopefully we'll have about a 20 to 30 minute discussion about arthritis and then leave some time for any questions. Have no disclosures to report. And so if you tuned into the ankle instability webinar a few months ago, some of these slides may look a little bit similar just for the anatomy. So first off, the ankle is mainly a joint that will go up and down, or what we call dorsiflexion and plantar flexion, similar to a hinge joint. And you see the green arrow here denoting the ankle. So there are 3 bones that make up the ankle. You have the shin bone or tibia, the fibula or the little leg bone that runs on the outside of the ankle, and then the talus, which sort of sits in there like a house that makes up a highly congruent bony joint that we refer to as the mortise. There are some ligaments that will help hold it stable. So you have the deltoid ligament on the inside or the medial aspect of the ankle. You have 2 paired ligaments on the outside of the ankle that give you your lateral stability. And these are the ones that tend to get injured in bad ankle sprains the majority of the time. And then you actually have ligaments that hold the tibia and the fibula together called the syndesmosis. And so you may hear about these with high ankle sprains in athletes, and they've been more publicized in the recent years. So essentially the bony congruity of the ankle is very high, and it's also held in place with strong ligamentous connections. And so when you think about ankle anatomy and ankle arthritis, it just sort of goes hand in hand that the biomechanics kind of lead to why we see these arthritic changes. So if you think about pressure as force over area, and you think about a joint like the hip or the knee that has a much larger surface area, there's going to be lower contact forces because the same weight is going to go through the ankle that goes through the hip and the knee. And so if you have a much smaller area, it's going to see much higher contact forces. Couple that with the fact that ankle cartilage tends to be much thinner than hip and knee cartilage. And that's how you can get damage with these injuries that leads to premature ankle arthritis. There's a classic biomechanical study that shows that just 1 millimeter of shift in your talus bone can lead to over 40% decrease in your surface area, and that can lead to some post-traumatic changes. And we'll talk about the types of arthritis, and that interestingly with the ankle, the post-traumatic is the most common, and it's probably related to these biomechanics and anatomical parameters that just even small injuries, if they're not fixed properly or go unnoticed initially, can lead to long-term consequences. And so it's just some things about ankle arthritis. I have a lot of patients and they're really, they know that they have hip or knee arthritis. They may have had a hip or knee replacement, but they're unsure as to what can even be done for ankle arthritis just because it is less common. The majority of patients will have some history of ankle trauma that may have already required surgery. So they've had a bad ligamentous injury or they've had an ankle fracture, 10 years ago that they thought they were doing fine from, and it's actually a result from that. If you compare those with ankle arthritis to those with hip and knee arthritis, they're on average about 10 years younger when they present. And then the age breakdown, if you compare 55 to 65, these are patients that still have good earning years with their careers and things. Are not close to being retired for the majority of the time. And this is just an average. So you'll see some patients that are definitely on the younger end of the spectrum that still may be in their 20s, 30s, 40s, and maybe they had a devastating injury as a teen or young adult, and now they're dealing with this ankle arthritis while they still have, a lifetime to provide for themselves and their family. And so it can be a big problem. If you compare treatment for ankle arthritis surgically compared to hip and knee arthritis, it's 10 to even 20-fold less common in the literature, but it's similar to shoulder arthritis, still less common. But a lot of this is registry data that's in the literature that is 5 to 10 years old, and I think the treatment for it is definitely getting more common. It's also inpatient registry data, whereas a lot of the joint replacements now, even at our surgery center, hip and knees can be done the same day at our surgery center. So if you redid that study, you're not going to capture all of the joints that are being done on an outpatient basis. So I think that in general that hip and knee arthritis procedures are more common now, but as are procedures for ankle arthritis, with it being more common and just more access to it on an outpatient basis, that the recovery is a little bit better than it used to be. So this is from sort of the classic textbook for foot and ankle. It just looks at the senior author of this textbook's causes of ankle arthritis. And what you see is that post-traumatic in his practice made up about 70%, which is pretty consistent over the literature, whereas you don't really see that breakdown in hip and knee arthritis. It's almost all osteoarthritis, some rheumatoid arthritis, and then rare to have as much post-traumatic arthritis, whereas the ankle is a pretty distinct joint in that most patients have had some history of trauma. And then this next slide kind of shows us a little bit more of what that trauma may be. So in the top left, this is a fairly standard ankle fracture that occurs from a bad twisting incident, or what they'll call a rotational ankle fracture that you see on line 4 of the table. And in his practice of the post-traumatics, which was 70% of everyone, 37% had a rotational ankle fracture, which I would say, most hospitals, even community hospitals around, have a handful of patients with these each week. And then at a trauma center, they're going to have much more. The second image on the left is a diagram and then x-rays of someone that has what's called a plafond fracture. And that would be the third line there. So you see that these made up 9%. And these are more of a high energy. So from a car accident, a fall from height, to where there's a lot of axial loading and impaction, and tends to have a lot more articular damage than a simple ankle fracture. I think that the fact that rotational ankle fractures made up a much higher percentage of the post-traumatic arthritis is just because they're much more common injuries. And then on the bottom left, just a diagram showing you ankle sprains. And if you look at the last 2 lines on the table, that recurrent ankle instability, which are people that have continued sprains, and then a single sprain with continued pain, this actually made up 25%. So if you take things that are very common, like ankle sprains that are causing continued pain and probably had some cartilage damage at the time that went unchecked, or patients that are recurrently spraining their ankle, it's leading to post-traumatic arthritis without maybe ever having, come to attention to someone. A lot of patients I see in my office are like, oh yeah, I sprained my ankle, once or twice a year, and just thought that that's how it was supposed to be, because it never really got better. And you see that, if you have one bad sprain and you get over it and you're doing fine, it's probably not going to lead to post-traumatic arthritis based on the data. But if you're having this recurrent instability, it puts you at risk for having post-traumatic arthritis. And so these are just some x-rays showing some patients with post-traumatic arthritis. And you see a lot of times if they've had an injury, they may have plates and screws in place from a previous surgery. These images on the right are someone that had plates and screws in that had been subsequently taken out. But what you see there is, there's a lot of the joint is narrowed. You see bone spurs. You should see a nice space between, the bones that you just don't see there. And so just looking at x-rays in general for ankle arthritis, the things that we classically see are that the joint space is narrowed, there's osteophyte formation, the bone gets hard and sclerotic, which you can see by just around the ankle joint, there's much wider bone, and then you'll see some cyst formation that's commonly seen more on advanced imaging that we'll look at in just a moment. I think with some of these that you can just tell that between the image on the top where you see that the ankle is tilted one direction and it almost looks like it's sliding out of the back of the ankle, whereas on the bottom right, you see that it's tilted in the opposite direction, that with arthritis comes deformity that a lot of patients will come in for. They just think that their ankle hurts and then it's been tilting one way or the other, gradually worsening. It's actually the arthritis causing it. And then along with that is you can also have some other deformities in the foot that drive the ankle. And so this is an example of a CAT scan that we got on a patient. You see these dark circles right along their ankle are bone cyst from the arthritis that sort of indicate that they've got cartilage wear and now that the bones are wearing and it's causing these cysts to form. And then occasionally, if a patient has less severe arthritis, we'll end up getting an MRI, and you can see with the arrows here that there's a bone spur coming off of the front of the tibia there that almost acts as something that's pinching down on the talus. The image on the right shows a bone cyst along the talus that's likely coming from that arthritis. So there are a whole host of conservative measures that we try with patients before ever even entertaining or talking surgery. And that's a good thing. So if it's been bothering you, it doesn't necessarily mean that you need surgery. And the majority of patients I see with ankle arthritis don't need immediate surgery. They need, good conservative treatment that may, last them the rest of their lives, or at least get them through their working years until it's a more convenient time to have something done. But activity modifications, and I see this with, altering your activities to do lower impact exercise, if that's what you're looking for, that, if you can only run a mile before it starts hurting, that you maybe run half a mile more frequently and things like that. Assist devices such as a cane, walker, crutches, things like that if needed. Anti-inflammatories if there's no contraindication. So steroids can work great on a short-term basis in non-diabetic patients. Anti-inflammatories can work great on a shorter term basis if you don't have any medical comorbidities that limit their use occasionally to keep your symptoms minimal. Tylenol can be good as a pain reliever. There's a Voltaren gel or diclofenac gels over the counter now. It used to be prescription only, but now it's readily accessible for about $10 at most pharmacies. And this can help some. It can be applied multiple times a day. Icing can be a strong anti-inflammatory and actually keeps symptoms very manageable. Move into bracing options. So something as simple as a lace-up ankle brace that you could get in our clinic or over the counter at a drug or sporting goods store or from Amazon, just depending on symptoms, can provide some relief. If this is not helping enough, some short-term offloading in a boot versus more long-term offloading. So something on the top left is called an Arizona brace. It's more of a custom leather ankle brace is how I describe it to patients, can limit the motion through the ankle and ultimately limit pain. On the bottom left is what we call a solid AFO or ankle foot orthosis, and it essentially takes away the motion of the ankle, which in theory should take away a lot of the pain. On the top right, you see a shoe modification called a rocker bottom. And basically, as you lose that motion with arthritis, this shoe tries to replace it. And you see this a lot of times. There are some Skechers shoes that have this built into it, and it can be a good option. And then occasional steroid injections can be a short-term fix to get patients good relief. And what I tell them is, I'm not trying to inject it every week or every month, but if it gets you 6 to 9 months of relief from your ankle arthritis, I think it would be worth it. And then we look into if all else has failed, surgical intervention. And there's a lot of treatment things or treatment options for surgery. I think the biggest thing that I get questions on is fusion versus replacement. And that's kind of how I've structured the talk. But other things, if you have someone with focal ankle arthritis, that their joint is fairly well maintained, that they may just have some bone spurs or osteophytes in a certain location, those can be removed with, arthroscopic removal or a small open removal, and then evaluation of the cartilage. And if there's loose cartilage, that can be removed. In certain cases, if there is a big deformity around the joint, the bone can actually be cut and try to rearrange the joint surface to make it more congruent to prevent worsening of the arthritis. There's a written about technique of distraction arthroplasty. I think it's very limited indications and don't tend to perform it. And then the big two that I see patients for are fusions versus replacement. I think we'll go into detail on both of these. And so on the left, we see a patient with significant ankle arthritis. It's slightly tilted with a mild deformity with significant osteophytes. And the biggest question is, the image on the top right is an image of an ankle replacement. The image on the bottom right is an image of an ankle fusion. And so what's going to be best for me? Most patients come in with an idea that they want a replacement or that they want a fusion based on what they've read before. And we just have a conversation about, well, what are the risks of one, what are the benefits? And what I tell everyone is it's patient specific. There's no perfect option that would fit for every patient. So we look at age, and, the younger the patient, the more I would tend to push them towards fusion, just because, as we'll see, it can be a better option with a lower reoperation rate at the ankle joint. Depends on activity level. Typically, the less active a person, the more likely they would do well with an ankle replacement, and they wouldn't wear through the parts or require a revision surgery in their lifetime. That goes along with age, that the older and less active is actually the better for ankle replacement. If a patient has a significant deformity, this could possibly be done in the same surgical setting as either a replacement or a fusion, or it could require a stage procedure. And some surgeons choose to do these, 4 to 6 weeks apart to try to get them all under the same healing time frame. Some are staged by a few months. The presence of neuropathy, or if patients have diabetes and medical comorbidities, depending on how dense that is, that may push someone more towards a fusion than a replacement. And then just looking at the overall medical comorbidities, and I try to have an honest conversation with patients of what their home life, what their house is like, how many steps, what are they going to do after surgery, how are you going to get around, because both require some period of non-weight bearing just to allow the skin to heal and the implants time to heal into the bone, or the bone to heal across. And so if we first look at ankle fusion, this has been long considered the gold standard surgical treatment for ankle arthritis. And what you do is, a lot of times with ankle arthritis, a lot of the cartilage has been worn away, but you would go in through a surgical approach and remove any remaining cartilage. You tend to take bone graft from one area somewhere else in the foot or ankle, or the tibia, and place it at the ankle joint. And then you compress it by some manner with either plates and screws or just screws alone. This can actually be done arthroscopically. And so patients will often have just a few roughly 1 centimeter incisions. It can be done through a small open incision or a full open incision. Again, a lot of these patients have had previous trauma and may have old surgical scars. And so that sort of comes into play as how it can be done. The surgery itself can be done as an outpatient, and often is. It kind of just depends on, if a patient has done some therapy before surgery, they feel comfortable not putting weight on it, and they're able to get around either using a rolling knee scooter for the majority of my patients, crutches, a walker or wheelchair, and who's at home. But the surgery itself can be done on an outpatient basis. Sometimes patients require a stay in the hospital, just depending on other factors. But it does require a period of non-weight bearing for generally 6 to 8 weeks, just depending on bone healing across the joint. This is kind of a schematic from a company, just showing in the top left that you would go in and any remaining cartilage is scraped off, and that gives you healthy bone surfaces, and then bone graft is packed in. And then in the bottom right example, it's compressed using a plate and screw construct, and then the skin is closed over that. Benefits. What's been documented in the literature is even though the ankle would no longer move, a lot of times you've lost some of that motion from your arthritis anyways. And once you've lost that motion, the joints around the ankle have taken up more motion to help out with your ambulation anyways. And so a lot of patients are actually, because they're in less pain, they have better ambulation than preoperative status, even though they may have less motion. There's a very low reoperation rate at the ankle joint, roughly 10% for non-union. In a healthy non-smoker with no evidence of vitamin D deficiency, it can be 10% or less. Those factors I mentioned, either vitamin D deficiency, smoking, and diabetes, increase your non-union rate, just meaning that bone does not knit across the bone surfaces and may have continued pain that would require a second surgery. The biggest sort of knock on the ankle fusion is that the joints around the ankle, since they're taking up more motion than they're designed to have, that they tend to get premature arthritis as well. And this was a radiographic study that found their ankle fusions, if they brought them back 10 years later, based on x-rays, 50% had arthritis at the joints around the ankle. They may not necessarily be symptomatic from that, or it may not be a debilitating level of arthritis, but it does occur. And then what we see is if you have to fuse other joints around the ankle, that it becomes harder to fuse those and has a higher risk of non-union. So you have less motion at the ankle, but you do get that motion through adjacent joints. And the studies show that patients with an ankle fusion tend to walk better than their pre-fusion state. Here are just some examples of some. On the left is a pretty soon post-operative x-ray showing someone with a small plate and screws. And this was done through about a 3-inch incision on the front of the ankle. The one on the right is screws alone, and this was done arthroscopically. So for this, you would have 5 1-centimeter incisions, which sort of limits swelling, limits wound healing complications, which is a nice part of doing ankle fusions. Let me see what I get. The more questions about is ankle replacements, that a lot of patients have had a hip or knee replacement and their ankle's bothering them. They've done some reading. And so with this, the joint is resurfaced, basically that the end of the tibia and the top of the talus are cut with a saw. And then metal components are put in, very similar to a knee. And then between those metal components, you have this, in the bottom right, you see it labeled as a mobile bearing. In the top right, it's the white piece of plastic between the 2 silver components, or a polyethylene. This can be done as it currently states right now for Medicare. It should be done at an inpatient facility. Lots of times, just depending on the time of surgery, I'll have patients stay overnight one night, and but it can be done on an outpatient basis as well, just depending on patient-specific factors. Non-weight bearing in this is a little shorter. Minimum is 2 weeks, just allow for wound healing. Oftentimes after 3 weeks, they're placed into a boot, allowed to start some ankle range of motion and some partial weight bearing, and then weight bearing in the boot until they're in the 6-week mark, and then gradually transitioning back into tennis shoes. If other procedures are done to realign the foot, that may limit the weight bearing to where you're fully non-weight bearing for 6 to 8 weeks maximally. So with an ankle replacement, we keep the incisions as small as possible, but as big as they need to be to limit tension. But it is an open approach. These are not done arthroscopically or through a true mini open. It's a full open approach. Again, having to incorporate previous incisions if you've had prior trauma. There's definitely an increasing use. We stated that the ankle fusion was long the gold standard for ankle arthritis, but I think that there's definitely a trend towards more ankle replacements now. But there is a risk that I tell patients is there is a higher reoperation rate with ankle replacements versus ankle fusion. So you're relying on new implants to incorporate into the bone, and they can loosen over time. The polyethylene or plastic component can wear down over time and need to be replaced. Lots of times patients will develop some bone spurs either on the inside or the outside of the ankle that may limit their motion, that may need to be removed. You can have fractures either during surgery or later after surgery, but it tends to be an early complication that may need to be addressed. Kind of along with that plastic wear, this can form bone cysts that ultimately need to be addressed to keep the implants from loosening. The biggest reported benefits are that you maintain some degree of ankle motion, despite what you have. Most patients come in with some degree of ankle motion. And then after the replacement, if you look at the studies, after a few years, it's about the same. It may be higher in the immediate postoperative period, but it does tend to stiffen up over a few years. But a lot of times it will be the same or even slightly better, especially if you've had someone that with post-traumatic arthritis, they tend to get more motion back. But this degree of motion that you have at the ankle tends to protect the joints around the ankle from getting post-traumatic arthritis or adjacent joint arthritis. And so there hasn't been long-term data in ankle replacements to show that. It's more of a theoretical concern or a theoretical benefit that if you're not fusing the ankle, that you're protecting the joints around the ankle. And so within the past several years, there's a variety of new implants available that now there's actually revision ankle replacement implants available. So if you had an ankle replacement 10 years ago and you're wearing through the components or they're loose, there are revision options. If you had an ankle replacement for 5, 10, 15 years and you're having some loosening and things like that, it can always be converted to a fusion. It may not be as straightforward as if you had a fusion to begin with. It may require different implants, but it can be converted to that. And then what I tell patients is there's a higher reoperation rate, but there's a lower risk of adjacent joint arthritis. These are some implants from one of the companies that makes total ankles, but there's probably 10 or 15 companies out there now that have implants, and more coming, every year or two. So here's some examples of some ankle replacements that have been done. The one on the left, the gentleman had a big deformity, and so we used one of the revision implants, but it was actually for his first surgery. And then the one on the right is more of a standard ankle implant with screws placed basically as rebar to prevent a future fracture. And so one thing that the patients ask is, well, what am I going to be able to do? I like to golf is the most common thing, or I like to play pickleball. Can I swim? Can I cycle? It became a much more common thing, especially during COVID. I think a lot of people found themselves at home and they had access to a stationary bike. And so that has definitely picked up. This was a study just a couple of years ago looking at return to sports after these. And so what I tell patients is you're not going to be able to, probably not going to jog, run, and jump very well. And I would probably stay away from those types of activities. There are very young people that get ankle fusions that may be able to go back to that, some of those things, but the vast majority of patients want to be able to walk without pain, walk on uneven surfaces, walk for distance, do some gentle hiking. When I trained out west, a lot of patients were interested in skiing, and I know we had a lot of patients with ankle fusions and ankle replacements that were able to get back to skiing, and then golfing, swimming, hiking. I think the literature supports that you can get back to this reliably with either. And so in summary, post-traumatic ankle arthritis is unique to the ankle, that it's the most common form of arthritis there, where it is not in the hip or knee. There are good data that you can get good pain relief and walk better with a fusion and a replacement, but it's a patient-specific choice that we have to make together. There's no single best treatment option for everyone. It's definitely on an individual basis. Prior to even discussing surgery, there are lots of non-operative options that may give you good pain relief, increase your quality of life, and keep you from ever having to undergo a surgery. But both surgical options, if you make it there, can improve your gait and decrease your pain. These are two resources that I commonly refer my patients to. One is footcaremd.org. It's a website written by other orthopedic foot and ankle surgeons, and essentially the top 30 conditions that I treat, they tend to have a page for it. And so you can read about ankle arthritis or anything else that might be bothering you. And the other one is the AAOS, which is the American Academy of Orthopedic Surgeons, that they have a specific section on foot and ankle diseases. Now, I'd love to answer questions.
Okay, thank you so much, Dr. Fraser. We have a few questions already. Someone has asked, are there any long-term negative impacts from frequent, and that would be 2 times a year, ankle injections to address sharp arthritic pain episodes?
I think if you already have ankle arthritis and you're getting injections to manage it. It sounds like it's lasting about 6 months if it's being injected twice. You can get deposits from the steroids. If the steroids are not deep into the joint, you can get some skin problems and things like that. If you're non-diabetic, or if you're diabetic and it's well controlled and not causing any problems with your glucoses and it's keeping your quality of life pretty good, I would say continue with that. It's not the same as if you were on long-term oral steroids for it. One thing we didn't touch on was other injections that are common in the hip or knee, like what we call viscosupplementation. Some people will call it a gel injection, and there's just not a lot of good data for it in the ankle. And so most of the time we're just injecting steroid or another anti-inflammatory. So I think if it's keeping your quality of life pretty good, to where you're doing what you want for the year and you just stop in twice a year for an injection, I think it's reasonable. If it's not lasting you 6 months, if it's lasting you 6 weeks or so, you should probably see someone about it to see if other options are available.
Okay, thank you. Another question, I see that icing is one of the conservative fixes. How about heat?
Yeah, I was trained that, get a bucket of ice, put some water in it, submerge your foot for 10 or 15 minutes in an ice bath is a good anti-inflammatory. I hear a lot of patients, especially if they have a muscular component of pain, a lot of patients have asked about Epsom salt, heat, warm soaks. I would say whatever works for you is completely fine with me, aside from, as long as you're not injecting substances into your foot or ankle yourself. I would say whatever works for you. There's a variety of over-the-counter balms and things and oils that patients try, and they say that it gives me good relief, it gets me through the workday, and I think that that's fine. If heat seems to work better for you than ice, I also think that that's fine.
Great. Next question. We have someone who says they were recently diagnosed with right ankle arthritis, mild Charcot. Ankle brace was recommended. Does OrthoSouth provide braces in-house? Because the outside vendor is possible.
Yeah, if I think I heard it right, it said ankle arthritis, and I think Charcot. Was that correct, Melissa?
Charcot.
Yeah. And so depending on how severe the Charcot is, it kind of determines what type of brace or cast you need. We do provide some treatments for these. Some are better handled by a prosthetics and orthotics company. I work with multiple prosthetics and orthotics company daily and talk with the prosthetist and orthotist daily from different companies. And so if there is a bad deformity that needs a custom brace, I will tend to refer to someone else. If it's something that could be managed with a commercially manufactured boot or brace that we have here, then we're happy to do that as well. But yes, we see patients with ankle arthritis and Charcot.
And we have one who is wondering, why does smoking increase the risk or healing time?
In general, smoking has been found to increase wound complication rates, decrease fracture healing rates, as well as increase fracture healing time. Just the toxic particles of the cigarette itself and the nicotine can slow all of the bone cells from healing. So typically before I do any elective fusion, I do require patients to stop smoking for that.
Is there a period of time that you require them to stop smoking before you will do the fusion?
We tend to do 6 weeks. And most patients are willing to do that just because their foot or their ankle has been bothering them so much. But the other thing that I tell patients is the soft tissues around the foot and ankle are very limited compared to the extra skin that most patients have around their hip or their knee. So if you have a wound complication around the foot or ankle that ends up needing more surgery or a plastic surgeon or anything like that, and you were smoking, it's just something that's not necessarily easy to quit doing before surgery, but it's almost something that could have been prevented most likely. And so I just have that talk with patients, especially if it's more of an elective procedure. If someone has a bad ankle fracture and they have to have surgery, then we have to do it. And we just discuss, the risk and benefits of continuing to smoke at that time.
Next question, are the same principles and or procedures fundamental to arthritic heel pain?
Arthritic what?
Heel pain.
Heel pain. So A lot of it just depends on what is causing the heel pain. So a lot of times when I see people for heel pain, if it's the back of the heel, it tends to be more Achilles related, which is not necessarily arthritic, but it's tendon degeneration that can cause bone spurs. Bottom of the heel tends to be more plantar fasciitis, which again can be sort of a chronic, almost tendinopathy that can cause some bone spurs. If you have the joint below the ankle between the talus and the calcaneus, is called the subtalar joint. And so I do see arthritis in that joint. There's not a well described replacement for it. And so the gold standard is if you have significant enough arthritis, would be a fusion of that, which is a pretty reliable operation for pain relief with a slightly higher fusion rate. And then you don't lose as much motion with that. So it just all depends on where that pain is coming from.
Fantastic. Next question. What surgical treatment is available for fallen arch that has caused the front of the foot to turn outward?
Yeah, so there are, again, a variety of options of that. Starting with conservative treatment, there's a good, well-described bracing options for it. A lot of times patients may have a flat foot, but it's just only part of that deformity that's causing an actual problem, that it's more of the tendonitis that's painful. And, I see a lot of patients and they say, my feet have been flat my whole life, but it's been hurting for, 6 weeks, 3 months. And it's something that we can get the pain to calm down, and then their foot is still flat. But if it's not causing pain and it's not causing callus and things like that, then we just treat it conservatively. If you have a flat foot that's consistently painful and not good relief with conservative treatment, there are options to realign the foot in sort of a reconstructive surgery for it that I'm happy to see you for in the clinic.
Excellent, thank you. The next question, someone says they have not explored anything to do with their ankle arthritis because they had heard that anything that disturbs that area would make the arthritis grow faster or grow back. Is that true? Is there truth to that? Is it something to be concerned with?
I would not ignore symptoms and fear that it's going to come back. A lot of times with things like anti-inflammatories, bracing, we're trying to calm down the inflammation and that process that's going on. Steroid injections are most of the time a temporary fix. Occasionally, patients get, long-term relief from it, but it's not necessarily that it's the arthritis coming back. It's just the inflammation is coming back, and you may need to look at other options. But I would definitely, if it's impacting your quality of life or changing, your activities of daily living and things that you like to do, I think it would be worth exploring the options and just having a conversation about it.
Fantastic. Does anyone else have any questions at the moment? I think we may have reached the end of our current round. We'll give it just a moment here. Dr. Fraser, this has been very educational, and I think we've covered a lot about foot and ankle arthritis. Do you have anything else you'd like to add before we wrap up today?
No, I think this will be recorded. If anyone has any questions or things that they wanted to look back over, me and my staff are, again, at 3 offices, always available to get you in to talk in person. And just because you come in doesn't mean that you're going to have to wear a boot or brace or get an injection. We can just lay out the options and let you pick what you think works best for your lifestyle, because the whole goal is keeping people active and as healthy as possible. So.
I have one more question. Are you very booked up right now? It sounds like you might be soon.
We can, I'm in clinic every day, at least a half day, so we can always get people in, especially if it's an urgent matter that's bothering you.
Awesome. Fantastic. Well, everyone, thank you so much for coming on to this webinar with Dr. Fraser. Dr. Fraser, thank you for being here and answering questions. This webinar has been recorded, so it will be on our website and available to come back and watch as many times as you'd like, or to share with family and friends who may be interested. Have a wonderful evening, and we'll talk to everyone soon.